All right, hi everyone. So today I will finish up chapter 11 and then do chapter 12. So that means after this video, we only have 3 chapters left, and those will each have their own video. So based on how I broke down the weekly schedule, those will each get their own week. So no more like 2 chapters per week or one and a half per week. So with chapter 11, what we have left is coping with chronic health disorders, co-management of chronic health disorders, and psychological interventions in chronic health disorders. And then chapter 12 is about terminal illnesses and dying. So before I get into that, just remember that the voluntary drop date is the 24th of July, so it's the last time to voluntarily withdraw from the course. And just keep in mind that your second Healthy Change Journal is due on the 7th of August. So it's still a few weeks away, but again, it will take a week to complete because you need to do a post-change recording of where your health behavior is at now. And what you'll need to do is attach that as an appendix, like just the one appendice at the back of the paper. And if those of you found that you were kind of rushing to do it last minute, you generally don't make your best work that way anyway, because I guess in theory you could write the whole paper last minute and just do the baseline recording for a week, but you're usually a lot better if you go at it a little bit at a time. So just try and keep that in mind, because it's crazy, but August 7th is going to come up really fast. Alrighty, so without further ado, we go into chapter 11. So, coping with chronic health disorders. So remember, these usually aren't cured, they're managed, and the person will usually live with them for, years, maybe even decades, depending on what it is and how old they were when they contracted it. So, although chronic health disorders can be distressing, a lot of people don't actually seek formal or informal treatment for the distress. They may address the actual disorder itself, but any resulting distress kind of just goes untreated and just left there. So instead, a lot of times people just draw on their internal resources, their coping strategies, and their social supports for solving the problems. And a lot of them do quite well. So what do? There's 5 common strategies for dealing with distress from chronic health disorders. First is that social support and direct problem solving. So people may talk to others to find out more about their situation, how to effectively cope. So if they know anyone that has the same condition, or a friend of a friend did, and they ask them what they experienced, what they went through, what they did to get through it. So that informational support. Distancing refers to mentally preventing the distress from impacting them, so just not letting it get to you. Positive focus, so instead of distancing yourself from it, just trying to put a positive spin on it. So identifying the strengths and benefits of the situation, like I'm going to come out of this stronger, or now I kind of see what really matters in life and what doesn't. For my fellow Swifties out there, I'm a huge Taylor Swift fan, have been ever since day one. And I remember in one interview talking about her mom having cancer, she said, I focus on the big problems now, not the little ones. Like my mom's cancer, that's a big problem. That's a real problem. So she wasn't necessarily the one dealing with the chronic condition, but it's the same idea of putting that positive. It could be a positive spin to notice what actually really matters versus what doesn't. Cognitive escape or avoidance. So the last 2 are both ways of escaping, but in cognitive, it's mental, right? So mentally or cognitively wishing the situation away. So maybe imagining a different scenario, like this isn't happening to me right now, I'm not here right now. And then behavioral escape is, physically escaping, maybe by eating, sleeping, drinking, drug use, going on vacations, that kind of thing. So all of these are could be effective in some situations and can have effective properties, but some are probably more effective than others. So the ones that work best, that are the most effective. So compared to dealing with other stressors, people managing stress from chronic health disorders usually use fewer active coping methods. So, less problem solving, things like that, and draw on more passive coping strategies, like, positive focus. So, not really doing anything about the problem, but more reacting to how they react. So, this could be due to lack of control present in a lot of chronic health disorders. So, say they have a form of cancer that the only way of treating it is with, say, like radiation or something. There's really nothing they can do other than choose to take the treatment or not. So then they're left with how they react and how they cope. So on average, avoidant coping strategies are related to more distress than approach-oriented strategies, because they're not, you're avoiding it, but you can't avoid it forever. It's still going to be there. Active coping with positive responses, soliciting social support, getting information, believing that you can exert some control over the situation, are all related to better adjustment and less distress. So yeah, you may not be able to change, like, will the tumor away. Maybe it's your diabetes is going to be there forever, so you can't do anything about having it, but you can control how you react to it. So you may not have control over the disorder itself, but there may be aspects that you can control. So understandably then, patients have beliefs about their disorder, and obviously this can impact the experience of it. So if you remember from chapter 8, people develop theories, like common sense belief models of illness, about their health disorder, including its identity, its causes, its consequences, the timeline, the prognosis, and how much they can control it. So one of the issues that may arise is how people interpret the nature of the disorder. So, for example, they may adopt an inappropriate model for their disorder. Like, most commonly, people classify and adopt a model that sees a disorder as acute, meaning it's curable, which is understandably a lot more comforting than saying it's chronic, because that means it's not curable. So this is important for healthcare providers, because if you're working with a patient that sees their disorder as curable when it's not, they're going to have a lot more difficulty adjusting and coping, because they have an unrealistic view of their actual situation. Further, people with chronic health disorders can develop beliefs about where the disorder came from, how they got it. So they may develop theories about the origins, like, so much stress, I developed this condition, or I got it from physical injury, bacterial infection, even a higher power like God, a spiritual authority. In addition to the origin, a lot of people need to understand where they got it from and put blame somewhere. And it could be themselves, someone in their family. And self-blame is really widespread with chronic disorders, especially ones that have a lifestyle component to it. And for example, people with diabetes, if they developed diabetes, they might blame themselves for not exercising enough, not having a good enough diet, like they got themselves in this position. And whether or not this is actually factually correct, because sometimes it is and sometimes it isn't, and a lot of times it's a bit of both, whether or not they are to blame, self-blame does little to help and to cope, and it can lead to guilt, self-reclamation, depression. Like, whether it's true or not doesn't change anything. Doesn't matter whose fault it is, you're here now. So self-blame can really not do a lot more than just make you feel worse about yourself. On the flip side, because nothing's ever completely good or bad, it can have adaptive properties. If it means, like, I got myself in this position, I can get myself out of it. So if you take that self-blame and use it to identify what things you actually have control over, it can be effective. But blaming another for the disorder is rarely effective. It's usually quite maladaptive, and it's tied to feelings of hostility, which can interfere with adjustment to the illness. And in comparison, forgiveness is a much more adaptive response. So if you imagine getting lung cancer from secondhand smoke, and maybe your parents or your partner or people around you are chronic smokers, you might blame them. But again, it does nothing to change the present. You're still here now. So that hostility can interfere with adjustment and take away valuable social support. And lastly, people develop a number of beliefs regarding how much they can control the disorder. So for example, Like I've said before, I have asthma, and I believe that I have a lot of control over it. If I exercise consistently, if I take the medication that I'm given, I live a relatively uninterrupted life. You wouldn't really know that I have it. And I know people can have varying severities of asthma, but someone else may view it that it's a hindrance. I can't run, I have asthma. So, whereas I see that I have a lot of control over it, I could also take the viewpoint that it prevents me from doing things, so I just shouldn't try. Overall, the more sense of control or self-efficacy that you have with your disorder, you're better adjusted and you adapt better. Like I said, you may not be able to control the disorder, but there's probably aspects of your experience that you can't control. Further, the experience of control can help prolong life and improve the prognosis of the disorder. So chronic health disorders can't be cured. There's a lot you can control, but if you find the things that you can control, this may help your quality of life and extend the life that you have. So moving on to co-management of chronic health disorders. Usually, because chronic health disorders have a lot of biopsychosocial impacts, it requires a lot of co-management from various avenues in the treatment and the management of the illness. Of them, physical rehabilitation is a primary one and involves a lot of different goals, specifically avenues of learning. So learning how to use one's body as much as possible in a safe manner. So with me learning how to exercise and recognize when it's triggering my asthma and when to pull back. Learning how to sense environmental changes and make the necessary accommodations. So learning to use physical management skills, so manage your body and your physical needs. Learning what your treatment regimen is, so what's necessary for it, and how that impacts your daily living. Maybe you need to take a medication at a specific time during the day or several times during the day. And how to control energy expenditure, because things may require more energy than they had previously. So physical rehabilitation is a key aspect of managing chronic health disorders. Many patients that require physical rehab have problems resulting from prior injuries, maybe from participation in athletic activities, and these problems are likely to worsen with age. So rehabilitation is necessary to keep that quality of life and preserve quality of life and even ensure you have a longer lifespan and quality of life for longer. In the development of a comprehensive rehabilitation program, pain management has to be brought in, because remember, a lot of times people fear pain more than death and more than most conditions. So people living with chronic pain usually needing medication, and they need coping strategies to not only alleviate pain but manage the pain with minimal cost to their quality of life. Further, people may need to learn how to live with adaptive devices, like now having artificial limbs or needing a wheelchair or a walker. So, understandably, chronic health disorders can impact various areas of our life, like professional, vocational, but they can also impact those most personal and intimate areas of our life. So we talk a lot about the impact on our social circle, but it can get much more intimate than that and impact your romantic life and your sexual life. So many chronic health disorders compromise sexual activity, whether this is due to physical consequences or secondary psychological factors. So issues may include impotence, fear of aggravating the condition, loss of energy, loss of physical capabilities, or a loss of sexual desire. And people may be really embarrassed or reluctant to discuss this area of their life, but it's a very important area, we know, for quality of life, for social bonding, social connection, self-confidence. So the ability to continue intimate relationships can improve and maintain your relationship satisfaction, which would therefore improve your emotional functioning. So as healthcare providers, it's important to not forget about this area and to check in on this area. So as with all interventions, adherence is very important, and it's very problematic for treatments of chronic health disorders. So consistent with the previous chapters, Adherence improves when there's proper education on the purpose of the treatment, like why we're doing this, its benefits, its possible limitations and consequences. And some people may not realize that seemingly innocuous areas of their life, like sleep, have an important role in their recovery and their treatment plan. So, your treatment plan may not just include what's prescribed to you. Adherence is predicted by high expectations for controlling one's health, so thinking that you have control and that you should take charge over your health, high self-efficacy, and knowledge of the treatment regimen. Chronic illnesses can create barriers, like I said, for vocational and professional activities. Some people require accommodations and/or restrictions to their work responsibilities and how they complete their professional tasks. Unfortunately, people may face discrimination due to their illness, and this is particularly true for, invisible illnesses and invisible ramifications of a chronic illness. So, for example, if an illness increases fatigue and decreases concentration, maybe the person needs to work in a specific distraction-reduced environment, or have shorter work days, or only work 3 or 4 days a week compared to the 5 that they did before. So a lot of potential job difficulties, it's better to assess them early on and try and predict them early on and communicate them between the person and their superior or their colleagues, like whoever's relevant, to ensure that all the issues are understood ahead of time, and this can help combat discrimination instead of trying to see what comes up. Understandably, reduced vocational and professional abilities can result in financial issues. So if you can't work as much or at all compared to what you used to before. Further, treatments for chronic illnesses can be expensive. So the financial needs may increase while, the financial gains are decreasing. So you might now have more costs than ever before, but you're not bringing as much money in. In Canada, with, OHIP, universal health care, there's a lot of things in place. We're quite lucky that kind of circumvent these issues. But in the US, this is still a very widespread issue, although it was started to be addressed with the Affordable Care Act. And after diagnosis, people may have problems continuing and/or establishing social relationships, whether this is due to real limitations or perceived limitations, or changes in how other people now perceive that person. So people may have issues adjusting to the individual's condition and their new state of living, and people may hold negative stereotypes about groups of people with chronic health disorders. For example, people who have AIDS face a lot of discrimination. And people with chronic health disorders may elicit ambivalence, so their loved ones may communicate warmth, but then non-verbally communicate dejection. For example, maybe someone says they understand you, they accept your issues, they're here for you no matter what, kind of thing. But then behaviorally, maybe they don't accommodate your needs or experience frustration when you change plans or something like that. So, understandably, families, I think your textbook says it's not just the person that gets the chronic condition, the families do too. Because families may be changed nearly as much as the actual person with the illness. One of the primary changes is the dependency of the person on their family. So this extends to children and spouses as well. These increased responsibilities may prompt reactions, whether intended or not, from the family members. So maybe now children need to step up and be more active in the household with chores or something than they were before. Or maybe the spouse now needs to be the primary caregiver. Children, in particular, because of their limited capacity to understand the situation and to regulate their own responses, they may experience regressions in their behavior, and they may act out, they may have difficulties at school, become antagonistic towards the family members. Marital disputes may increase, so a didactic coping strategy is useful to deal with a lot of this stuff. And in a didactic coping strategy, there's a we approach to managing the issue. Not you do this and I'll do this, but let's tackle this together. Whether the caregiver's a friend, a family member, a child, a spouse, a neighbor, etc., the role can be quite burdensome. being a caregiver is exhausting. On average, women are more often caregivers than men. A lot of this is due to the fact that we live longer than men. Understandably, the caregiver role can result in stress, biological wear and tear, psychological distress, and strains on the relationship between the person and their caregiver. And a lot of this may come out in, the patient's perception of the situation. So they may be resentful of their condition, embarrassed that they need this much help, and they may project those feelings onto their caregiver and act unappreciative and angry. And that's really hard to take, even if the caregiver knows that they're not actually angry at them, they're angry at the situation. It's still hard to experience. On average, caregivers cope better when they themselves have a strong sense of self-efficacy, mastery, good family functioning. However, they can't be forgotten in this equation. So a lot of times the caregiver gets overlooked because a lot of the attention goes to the person who's actually dealing with whatever the condition is. So services for the caregivers can be nearly as important as the services for the patient. So looking at demographics, there are gender differences in the management of chronic health disorders. On average, women with these chronic health disorders experience greater loss of social support. This could be related to their decreased likelihood to get married or to stay married compared to men with disabilities or chronic health disorders. When married, women with chronic health disorders are more likely to be placed in assisted living situations compared to married men. The reasons for this it doesn't boil down to a single known reason, but it's possible that when men are married to a woman with a chronic health disorder, they don't feel as capable to care for their spouse, or they may have disabilities of their own. So less is known about non-heteronormative couples, like gender non-binary, gay couples, lesbian couples, but it's definitely an important avenue to consider. And lastly, there are positive changes to note that may arise from chronic health disorders. So people may experience positive emotions like joy and optimism as they overcome, cope with, manage their disorder. Further, this may serve as an indication of lost time, so prompting people to find meaning in their lives and not be held back by thoughts and concerns, like figuring out what the big problems really are. Their troubling experiences may promote feelings of empathy and compassion for others, and this may help reduce judgment and apathy. Like if you find yourself disabled and you'd had judgmental thoughts towards people with disabilities before, and now you realize how difficult it actually is to get around for people with disabilities. And lastly, people's ability to cope and manage a disorder may result in them feeling stronger, self-efficacious, and self-assured. So a chronic health disorder can be difficult enough in an adult. In a child, there's definitely additional difficulties existing. So depending on the age of the child, there can be significant limits to how much they can understand about their diagnosis, what it means, how to treat it, what this looks like for them. Further, recall that much of the health behaviors in children are dependent on their caregivers. So children usually require significant aid and management from the family to follow the treatment regimen. Treatment can create limitations or adjustments in a child's life that they don't understand, that they don't like, and this can include things like restrictions on physical activity. So they may not understand why they can't play soccer or play tag with the other kids. Additionally, treatment can require that a child's exposed to isolating and potentially frightening procedures. Sometimes the caregivers can be there, but sometimes they can't, and they have to be separated. So this can be really problematic and possibly traumatic for a child. So because children can have a limited capacity to understand, let alone communicate their experiences and their distress, they may communicate them in different ways. So children suffering from chronic health issues can end up exhibiting behavioral problems like withdrawal and rebellion. They may struggle in school, refuse to adhere to their treatment, especially if it has side effects or any requirements that they don't like. They can, again, exhibit regressive behavior for whatever their age is, so maybe bedwetting. Further, they may experience low self-esteem, possibly view the disorder as punishment for bad behavior, and possibly feel resentment towards their healthy peers. So being aware of these possible ramifications among children is really important to ensure that they're addressed, that they're interpreted correctly by the adults in their lives, and that the child can develop effective coping strategies to manage their situation. Children with chronic health disorders are at risk for developing more maladaptive coping strategies to manage their condition, like possibly repressing their issues, not talking about them. And this can interfere with their ability to ever really understand, manage their disorder, communicate how they're feeling. So then what do we do? How do we help them cope? Because remember, it's best to try and learn the habits in childhood so that for any health behaviors, that they develop into habits in your adult life. So parents and caregivers can have a significant impact on improving a child's coping abilities. If a caregiver has a realistic attitude of the child's disorder and their condition, they're better equipped to soothe the child emotionally and provide an informed basis for care in a way that the child will understand. So this means not bubble wrapping them because you think their condition makes them so fragile. And this means appreciating whatever ramifications exist. So caregivers, again, with a sense of mastery over the child's health, like that you know what to do, you can handle it. Parents who aren't depressed themselves and can effectively express their feelings, so can avoid expressing distress ineffectively, like maybe breaking down if a child is receiving treatment. These are all predictors of better adjustment for the child. Further, children should be encouraged to be involved in their care as much as they can. Just because they're kids doesn't mean they can't play a role. Restrictions on their lives should be reasonable and realistic, not over or under implemented. So when possible, they're encouraged to attend school regularly, live their normal life, engage in a reasonable amount of physical activity, socialize with other children, be a kid as much as they can. However, caregivers and families aren't always well equipped physically, mentally, financially to cope and to help the child cope. So they're doing the best that they can, but it just depends on what they have to work with. Sometimes interventions are needed to help the family get through without further distressing the child. So in these cases, family therapy is helpful to discuss effective ways to cope. Additionally, involving the family and training them in the treatment regimen is helpful to educate and provide a sense of control over the condition and the treatment. So, finishing off with interventions in chronic health disorders, there's numerous forms of psychological interventions. Firstly, there are psychopharmaceuticals. So there is medication to help treat symptoms of depression and anxiety that may arise. So it's common among these situations to prescribe anti-anxiety or antidepressant medication to help alleviate this additional distress. Individual therapy is really common to treat psychosocial complications from chronic disorders, but it's administered a bit differently than psychotherapy with patients that don't have primary medical issues. So firstly, therapy is more likely to be episodic compared to an individual who may present for, weekly sessions or more, but like regular prescribed sessions. These individuals with chronic health conditions may attend sessions intermittently because their conditions may flare up for a period of time and then have a period with no symptoms. So consequently, they may need some regular therapy for a period of time and then be okay for a while. Additionally, session length and frequency may vary depending on the client's energy level and their cognitive capacity, so what they can handle. Collaboration with the physician and the family is crucial with this kind of therapy. So including the client's full circle of care helps ensure that everyone's in the know as much as they need to be. So the clinician's getting good updates regarding the client's condition. And third, whereas therapeutic modalities classically attempt to challenge the defenses. So if you find there's a psychological defense in play, you want the client to be aware of it, see why it's there, how they can get around it. Individual therapy with clients that have a chronic disorder may require that their defenses are just left alone. This is particularly true for chronic and terminal conditions. Their defenses may serve as a protective factor with little consequences and can actually protect them from realizing the full ramifications of their illness. And lastly, and most complexly, is the clinician needs to understand the client's disorder and its modes of treatment. So they have to have a bit of, they have to educate themselves on like the medical side of the client's condition. Both the health disorders and the treatments may produce psychological symptoms. So the clinician that doesn't take this into account may make inaccurate assumptions regarding the client's mental state. Like maybe they are depressed, but if it wasn't for, the treatment or the condition or both, they wouldn't be depressed. Coping skills training can be really effective for improving functioning in people with chronic diseases. So these programs are usually directed at increasing, knowledge about the disease, reducing anxiety, especially anticipatory anxiety about what you don't know, increasing the patient's feelings of purpose and meaning in life, reducing pain, depression, improving coping, obviously, promoting adherence to treatment, and increasing the person's confidence in their ability to manage their condition. Additionally, relaxation training is widely used with chronic health disorders. So combining relaxation training with stress management and blood pressure monitoring is an effective method for conditions like hypertension. And if you remember, mindfulness-based stress reduction, MBSR, and acceptance commitment therapy, or ACT. So MBSR teaches people to be highly aware of the present and accept and acknowledge feelings, thoughts, etc. without being consumed by them. And relatedly, acceptance and commitment therapy is helping individuals accept their health disorders without avoidance or denial. So both forms of therapy have been used with people that have chronic health disorders, helping them cope, and have been connected to better adjustment and better coping. Because like it sounds, you're not fighting it anymore, you're not focusing on the things that aren't here yet or have already happened, you're just kind of accepting and working towards your values and living in a life that you value despite all this stuff. Further, exercise is often forgotten, but a very valid treatment because it really improves and maintains quality of life and instills that sense of mastery in the individual. And lastly, as you recall, social support is a very important resource, and this is particularly true for those with chronic health disorders. The benefits of social support have been demonstrated for nearly every chronic health disorder. Among forms of social support, family support is very important. It enhances the person's physical and emotional functioning, promotes adherence to treatment, and can improve the course and prognosis of chronic disorders. Family members may provide emotional support, and pragmatically, they can remind the individual of daily activities and treatment considerations they need to take into account. Support groups are really valuable and kind of an interesting special area because they're a group of people that have similar issues and can discuss issues of mutual concern coming from chronic health disorders that other people just may not be able to understand. So they can give a valid form of informational support regarding how to cope with the problems of the disorder, what to expect, and can provide a validating space to share emotional responses that people experience as they live with their disorder. So these social support groups may add to support that's already given by the family and provide this unique form of support that may satisfy unmet needs. So even the most empathic person in the world, if they've never experienced it, there is a limitation, and the social support may fill that void. So that wraps up chapter 11. Now moving on to chapter 12 about issues in terminal illnesses and like death and dying. So death is a pretty weird thing to talk about sometimes. People may feel like uncomfortable, afraid, a little bit defensive, but it's a natural part of the human experience. We're all going to die at some point. And much like many illnesses are stigmatized, the stigma, the taboo surrounding death can contribute to a lot of issues adapting to death when it does come. Or, like in terminal diseases when you know it's approaching. And unfortunately, death isn't reserved for the elderly, and it can occur at any point across the lifespan. On average, people live about 79 years, with cisgender women living longer than cisgender men. However, with the rise in chronic illnesses, most deaths are now attributed to these chronic conditions. And that means that a person's death can be anticipated for years, maybe even decades before it actually happens. So for example, someone may know that they'll die for 5, 10, even more years before they actually do. So because of this, investigating, how people experience death and dying, the impact that it has on them, and, the experience with terminal disease is really important to ensure that this growing population of individuals can achieve a good quality of life for as long as possible. So understandably, death in infancy and in childhood is probably one of the hardest demographics to accept. Unfortunately, there's clear racial differences in infant mortality rate, with African Americans and Hispanic infants more than twice as likely to die in their first year of life than Caucasian infants. A primary contributor to infant mortality rate is affordable maternal care programs. So when infants are born prematurely or when they die at birth, the problems can frequently be traced back to poor prenatal care. In the first year of life, the main causes of death are congenital abnormalities and sudden infant death syndrome, or SIDS. And SIDS is a condition in which the baby suddenly stops breathing. And the causes of SIDS aren't entirely known, but we do know some risk factors that have been noted. So SIDS is more likely in low SES environments, when the mother smoked during pregnancy, and if the baby is put to sleep on their stomach or on their side. After the first year, but before age 15, the main causes of death for children are accidents and cancer. So accidents are the leading cause and account for 40% of all deaths in this age group. And the type of accident that is most likely shifts depending on the age of the child. So in younger children, accidents are more commonly due to accidental poisoning, injuries, falls in the home, as children get more mobile and start exploring and getting into everything. In later years, automobile accidents take over and become the primary cause of accidental death in children. So second to accidents is cancers, and leukemia is the most common form of cancer that results in death in this age group. So in adolescence, or skip the slide. So if you remember from chapter 11 that children have a limited capacity to understand, and this could be limited in how they understand things, how they picture things, how they express things. So this is the same for death as it is with chronic illnesses. Children's understanding of death appears to develop slowly over time. Up to age 5, children appear to think of death as kind of a great big sleep. So they're usually more curious of death compared to being frightened or saddened by it. So this may be because they don't fully understand that death is irreversible. They're not coming back. They're not asleep. So, I can remember I was 5 when my Opa died, and I sat, during the visitation, I sat right beside his casket the whole time, like his little buddy, hanging out with him. And I don't really remember what I was thinking back then, but I definitely didn't comprehend that being dead meant he was gone, right? Rather, children in this age may conceptualize it as an altered state. So if you think of the Disney characters like Snow White. Now, between the ages of 5 and 9, children begin to understand that death is final, it's irreversible, and it's not a great sleep, it's not an altered state. When you're dead, you're dead. Nonetheless, they don't usually have a full biological understanding of what's happened. The body is shut down, the body's going to start to break down. They may view death instead as a personified character, like a shadowy figure the Grim Reaper or devil who's going to take the person away. So this may result in a lot of fear and a lot of sadness over death. And then by 9 to 10, children start to understand and develop into that eventual adult understanding of death, that it's inevitable, it's universal, everyone's going to die at some point, and it's a natural part of the course of life. So at this point, the child understands at least some of the processes of death. So it's biological. There's usually some form of ritual or something that follows, depending on the culture, backstories, like a funeral, a burial. They know that the body will break down, the person won't come back. So when I think about how I was when I was 5, when my grandfather died when I was 9 or 10-ish, at this point I understood that he was gone, why he was gone, what the processes were, that he was permanent, or that it was permanent. So as you get older, you start to understand a bit more, and this can influence their reactions to death based on how they picture it at that time. So now moving on to adolescence and young adulthood. Most would view, if you asked young adults, adolescents, if they would die, what do you think would cause it? Most would view possible causes of their death as coming from like some kind of accident, some kind of form of tragedy, because on average, people don't die when they're young. Everyone dies, but it doesn't mean every death is natural. Unfortunately, this estimate wouldn't be far from the truth, because the major cause of death in this age group is unintentional injury, which mainly involves automobile accidents. The second leading cause of death in this age group is homicide, which is the leading cause of death among Black men. So again, keep in mind there are these demographic characteristics that make a big difference to you. The third is suicide, and this is followed by cancer. And the remaining deaths are usually attributed to heart disease, AIDS. Unfortunately, because it's not commonplace to die at this age, death in this population is most often attributed to, most of these are the sudden tragic cause. So this is understandably very difficult for those left behind and for the adolescent themselves, especially when it is something longer, like a terminal illness. So as with the death of a child, a young adult is considered tragic and hard to process. For young adults given a terminal diagnosis that actually have time to think about the fact that they're dying, they may experience shock, outrage, a sense of injustice as their lives have barely begun, which, makes sense. So compared to the elderly who may be in, a better state to accept their diagnosis because they've hopefully had a long, fulfilling life, a young adult with a terminal illness may become angry and resentful and struggle to accept that this is their diagnosis, this is their situation. Making matters more difficult is because they're young, often, their disorder aside, they're generally much healthier than, say, like an 85-year-old would be. So they may face a much longer, drawn-out period of dying. Something that may result in the death of an elderly individual in a matter of months may take much longer, maybe even years, for a young adult. So there are fewer biological competitors for death in the body of a young adult. Their body is stronger, so they're less likely to develop and or succumb to complications like organ failure and pneumonia. So moving on to middle age. In middle age, the idea of dying becomes more realistic, both because it's more common as the age increases, the rate of death increases, and because chronic health issues are more likely to develop at this age, and this may or may not lead to death depending on the chronic health issue. So the fear of death may be conceptualized at this point as a fear of loss of valued aspects as well, such as physical appearance, athletic ability, sexual desire. So it's not just, I'm not just going to die, but I'm going to deteriorate and won't be able to do the things that I want to do. So if an individual dies before the projected age of death, which on average is 79, this is known as premature death. The main cause of premature death is heart attack or stroke. So if you went and asked people how they'd like to go, the majority would probably say they'd like something sudden, like painless, non-mutilating sudden. For those left behind, a sudden death can be more painful in a way because they don't have time to expect it, to prepare for it, to cope with it. However, at the same time, it can be a bit of a blessing because they don't have to witness, worsening condition. They may be less of a strain on resources like time and finances. And for the individual, it may be a bit more of a graceful departure, depending on the circumstances, because they don't have to ruminate and attempt to cope. Like, there's no thinking about the fact that I'm going to die. Overall, death in this middle age group has declined, largely due to a reduction in smoking, so then a reduction in smoking-related lung cancer. However, there are still demographic differences in death, with Caucasians living longer than African Americans by 1 to 2 years on average. And SES is a strong determinant of age of death. With, the higher your SES, the higher age of death. You have access to more resources. Unfortunately, people treat you better when you're a higher SES, like there's less stigma. And this accounts for much of the racial differences because there's a definite imbalance and discrimination in SES and racial minority versus Caucasians, your ethnic group. So understandably, moving on to old age, death in old age still isn't easy. It's never easy to lose someone. It's never easy to know you're going to die. And yet people are usually much more prepared for and expectant of death in this age group. So often, you just know that the higher your age gets, the greater the likelihood of dying. And these individuals will usually have started to see their friends and their family members die and thought about their own deaths and made preparations. So it's no longer, your grandmother died. It might be your friend or your spouse. On average, the elderly die of degenerative conditions like cancer, stroke, lung failure, heart failure. Additionally, natural physical decline can predispose them to infectious disease or organ failure. Compared to young adults, there's far more biological competitors for death, right? So it makes a terminal illness phase shorter for individuals diagnosed. But nonetheless, some people not only make it to that projected age of 19, but they fly past that and may live even decades longer. So why do some people hit 79 and, that's as far as they get, and other people get into the hundreds and, can still be walking around? Obviously, worsening existing conditions and contracting new illnesses account for a lot of this. So if an individual had a chronic condition for years, they have a lower chance of living long and, hitting 100 compared to someone who has had no chronic condition. But changes in psychosocial factors play a huge role too. So poor mental health and little life satisfaction predict decline among the elderly, and a sense of purpose is tied to longer life. So often the elderly slowly lose their ability to control or contribute to different areas of their life. They may not be able to drive anymore, make their own food, garden, etc. Adding aspects of purpose and aspects of control in their life can help their mental state and then their overall quality of life. So I remember, I think it may have been in Intro Psych a long time ago, I read about a study years ago in which elderly individuals who had a plant to care for, so just a plant, reported better mental and physical health compared to those who didn't have a plant, because it just gave them something to do, something to look after, something they had control over. Understandably, the focus of health among elderly then has shifted not to preventing death, because it's inevitable, it's going to happen, but preserving quality of life, not necessarily prolonging it. Let's just make what you've got as good as it can be. Promoting safe physical activity, so keeping them active and moving in a way that's safe for them. Social connection, purpose in their life, in addition to, good diet and exercise, has helped maintain the health of aging individuals for longer. So one factor of interest that has remained consistent over the years and numerous research is that cisgender women live longer than cisgender men. And after you account for this difference, that 79-year expectancy age changes. So for women, it goes up to 81, but for men, it goes down to 76. So there's a lot of different possible factors that attribute to this, and there's a box in your textbook that goes into detail in this. So things like women have a lower propensity to engage in risky behaviors compared to men, like smoking or occupational hazards. And it's more socially acceptable on the stigma stereotype side for women to seek healthcare. So if you go back a few chapters, it's more like women use health services more, possibly because it's more socially acceptable for them to seek health care compared to men. And it's more socially acceptable for them to lean on social support compared to men. So this may impact their longevity. So understandably, there's psychological and social issues related to dying. Some people die suddenly, but a lot of times, especially with the rise in chronic illnesses, people know they're going to die for some time before they actually do. So there's a lot of different psychosocial issues to consider regarding people's experience with death and upcoming death. Advancing illnesses may threaten the person's self-concept, who they are, who they want to be, how they want to be perceived and understood by others. They may have a limited ability to present themselves in a way that they want to, including things like controlling their biological and social functioning. For example, they may have to wear incontinence pads or may find themselves incontinent during social situations. They may have distorted facial expressions or movements, and they may have a limited ability to properly read social cues and respond to them. They may have intermittent pain as well and may experience deterioration in their appearance, maybe from weight loss, from stress, etc. For many, the physical deterioration is less distressing than the possible mental deterioration. So it's one thing to lose a bunch of weight and not be able to walk, but to lose your ability to remember, to communicate, to know who people are. So these may come from cognitive decline from aging, like natural cognitive decline, or maybe a progressive disease, like if you have Alzheimer's, or even a side effect of treatment. So these issues usually extend to impact social interactions and relationships. Although those with terminal illnesses usually want social contact and definitely need social contact, they may be concerned for those around them and leery of how their condition will affect their loved ones. So to protect those close to them, it's common for people to withdraw and to reduce social contact. To ensure that the person gets the social support and the contact they need, and to manage any secondary distress from being isolated or anything, family members could schedule visits, so you know who's coming and when they're coming, and discuss the person's condition with the people visiting so they know what to expect and they can better monitor their reaction. Also, honest discussion about who can and can't control themselves, and thus who should abstain from some visits may be helpful. It's not personal, it's just keeping things as least distressing as possible for the person who's actually needing the support. So third, these issues usually extend to impact social interactions and relationships. Or third, communication issues may arise as the person's condition deteriorates. So if the prognosis worsens or because of it treatment becomes more extreme, then medical staff may become evasive and vague if questioned about the patient's status, because they may feel uncomfortable sharing consistently grim news. Like if someone's asking how are they today, and for the 10th day in a row the answer is not very good. Family members may have a form of their own form of denial and may try to put a positive spin on things, which can be helpful when it's realistic and when it's used adaptively, but they could have an unrealistically positive prognosis and try and remain optimistic with the person. But then with the medical staff, they're a lot more fearful because they're not trying to put on that brave face. So, as stated, talking about death is usually uncomfortable and taboo, and people don't like it. I've had a very wise supervisor tell me that, with clients, I should say, like, they died, they didn't pass away. 'Cause you're not trying to change the situation or avoid talking about death. Just normalize the terms, normalize the words. But because it can be so uncomfortable, people may avoid the topic, especially with the person that's dying. But it really just may be better to bring it up, reduce the stigma, let everyone know that it's okay to talk about it. Talk about the elephant in the room. So if you think back a few chapters to the discussion of complementary and alternative medicine and the potential issues and risks that arise from using non-evidence-based medicine, this is an issue with terminal illnesses as well and the use of non-traditional treatment. As health and communication deteriorate, many terminally ill people turn to non-traditional treatment, and sometimes they may spend thousands of dollars and hours of their time and effort looking into fringe publications and like clinical trials that have just begun and that could be dangerous, and may spend a lot of time using treatment coming from unsuccessful research that could possibly work with them. And why do people do it? Some people are looking for a miracle cure that will save them, especially if they're having trouble coping and accepting what's going on, looking for that miracle. And also save their loved ones from the pain and the stress of watching them die and dealing with their death. In other cases, disappointment and anger from a deteriorating relationship with conventional healthcare may make someone turn to non-traditional treatment as an alternative. So if the healthcare staff maybe are using treatment that the person doesn't like, but they have no choice because of ethical considerations, or they just feel that they're not being communicated or treated appropriately. And a lot of this is because there's a huge humanistic focus in non-traditional treatment. So a lot of it has a much more humanistic basis, more client-centered, and this may be attractive to the person, regardless of the risks or the validity of treatment. Although a solid patient-practitioner relationship isn't sufficient to stop people from turning to non-traditional treatment, it's important as both a preventative factor and for the overall quality of care to pay attention to that relationship and to preserve it as much as possible. So how does one die when they know what's going to happen? Not like physically how does someone die, but if they know what's coming, what's that mental process of dying like? So Kubler-Ross developed a theory on the 5 stages of dying and suggests that people generally pass through these 5 stages as they adjust and as they approach their death. So you may have heard them as the 5 stages of grief: denial, anger, bargaining, depression, and acceptance. If anyone's seen The Haunting of Hill House on Netflix, I read an article, I don't know if it was actually validated by the people that made this, but the idea that the 5 Crane children represent the 5 stages. And when you see it, like when you read that, you can kind of see it. So although research suggests that people may not pass through these stages in that exact order, it's pretty common that people will experience all 5 of these at some point in time. So going through them, in denial, it's thought by Kubler-Ross to be the initial reaction to the terminal diagnosis. So remember what denial is. It's one defense mechanism to protect from psychic pain, and it's a defense in which people avoid the implications by denying their existence. So most in adults, it's usually a mature version of like a very basic childlike one that you might see in kids, like, did you eat the cookie? And they say no, and they have crumbs all over their face. I didn't do it. So if I deny that it's there, if I deny that it happened, then it didn't happen. In adults with terminal diseases who are facing death, they may act as though the illness is not severe, that it'll go away, that, there was that one miracle case with so-and-so in wherever the place, so that could happen to them, it could go away. In extreme cases, the person may deny that they have the illness. Like, there's false positives all the time. They got it wrong. Thus, denials that mental blocking of the full realization, the reality, the implications of their disorder and their condition. Early on, it can be helpful. It's really common. Most people experience it, and it can be helpful early on to protect the person from that realization before they're in a position to do so. On average, it usually only lasts a few days, but if it goes on longer and if it's more severe, it may require some psychological intervention to help come to terms with it. Now, second is anger, which is, the patient asking, why is this their fate? They didn't deserve this. Like, so-and-so did this their whole life and they never got sick. Things like that. And this is a really hard stage for friends, family, medical staff, the people around them to deal with. The individual may show resentment towards anyone who's healthy, who isn't dying, such as the medical staff, their loved ones, their friends, etc. They may become very embittered, making jokes about death, about their deteriorating appearance, capabilities, the things they won't be able to do anymore. Those around them may be left feeling really unappreciated or blamed for their condition. So, to help address this and manage this stage, it can be really helpful for a therapist or someone to be involved and help the family understand that the anger is being misdirected at them. It's not actually truly being directed at them. The person isn't actually angry with them. It's just, they're letting it out somewhere. And it doesn't make it okay or effective or easy. It's just, they're not actually angry at you. So that third stage is bargaining, which, as it sounds, it's people attempting to trade good behavior for good health. Like, if I get through this, I'll never drink again, I swear. I'll give back to others. I'll do the best I can, things like that. It can look like a pact with God or some form of spiritual entity in which the person agrees to stop a behavior or begin some good behavior in exchange for more time. It can, sudden rush of charitable activity or being really, really uncharacteristically pleasant can kind of arise as a result of someone in that bargaining stage. Depression begins as a person comes to terms with their fate and the lack of control that they have over their fate. So this may arise possibly from a worsening condition, failing treatment, tangible evidence that the illness will result in death. At this stage, the person may feel tired and drained, hard to eat, focus attention, and escape pain. So Kubler-Ross described this stage as the time for anticipatory grief, where the person starts to mourn their own life and the prospect of their own death. This process may occur in two stages. So first, the person comes to terms with the loss of the things in their past. So past valued activities, past friends. And they begin to anticipate future loss of whatever's left. So the remaining activities they can do and their remaining relationships. So although depression isn't pleasant, it can be functional as people begin to prepare for the future, because it may be an indication that there's no more denial or bargaining or anger. There's an acceptance that we're reaching acceptance that this is where things are. And lastly, acceptance, the person may be physically and psychologically too weak to fight or to be angry. Additionally, or alternatively, they may have come to terms with their fate and be used to the idea by now. The idea of dying, that it's going to be happening sooner rather than later. A tired but peaceful calm may arise as a result, though this may not be pleasant. It doesn't mean you want to die, you're looking forward to it, and you're glad it's happening, but it's like, okay, this is how things are. And in this phase, people may begin to make those final preparations, dividing up possessions and saying goodbye. So again, it's not that people are happy about it, but they're not fighting it anymore in any form. So remember that any theory has advantages and it has limitations. So with this theory, a primary limitation is, like said before, in real life, this order isn't usually fixed for everyone. People don't go through those stages in the same order all the time. People usually experience each stage at some point, but it can be in whatever order. And I mean, people may regress, like pass through one stage, go to another one, and then go back to one that they've already been through in their own journey. because this may depend a lot on, their body, like how they are physically in their illness and in their condition. If all of a sudden they get a surge of energy, and their symptoms are reduced for a period of time, maybe they'll go back to being angry because they now actually have the energy to do so. Additionally, this theory doesn't explicitly account for anxiety's role in dying. And anxiety is really important. It's scary to know that you're going to die. Next to depression, anxiety and fear over dying is one of the most common responses. Much of the fear and anxiety is related to pain, and sometimes people even hope for death to escape pain. And it's definitely not a stage in that theory to actually hope for death. So it's a very unique conditions that anxiety can create. Other symptoms might produce anxiety, like shortness of breath. So it's not anxiety related to the fact that you're dying, but what you're experiencing. And this anxiety can also exacerbate the condition, so impacting their experience with dying, maybe speeding it up. So anxiety plays a huge role in a person's experience with dying. Can even make a person hope for death. So it's definitely a big limitation of the theory that this isn't considered. So it's a lot of conversation about the impact on the caregivers and on the person that dies. But then what about the professional caregivers? Or what about the professional caregivers and the family, the people that see death every single day? So those working in palliative care, oncology wards, things like that. Terminal care is very hard on healthcare workers. And from a professional standpoint, it's kind of like the least interesting care, for lack of a better term, because there's little expectation to heal the patients or for change in their functioning. So other than deterioration, you're really not expecting much to happen from a professional standpoint. Terminal care is palliative, meaning it's not curative. So because curative care is designed to cure a disease, as the name suggests, and heal the person, palliative care is designed to make the patient feel as comfortable as possible given their circumstances as they live out the time they have left. So for example, in many long-term care homes during COVID, all visitors were prohibited for obvious reasons, and in some cases, exceptions were made for palliative patients because they're not going to get better. So you just try and make them as comfortable as possible for as long as you can. Much of palliative care is unpleasant custodial work. So, feeding, bathing, changing patients. So again, for, the perspective of someone that wants to continuously learn and grow in their profession and be interested in their profession, it's a lot of just repetitive work. Not that there isn't a lot of change other than deterioration. Additionally, healthcare workers see this regular deterioration, see symptoms that maybe they can't address because of complicating factors. Symptoms may go unmissed and may be found too late, and death is a regular occurrence. So this can result in burnout among staff members and a lot of psychological distress from seeing this day in and day out. So they need to do something to protect themselves. And to do so, sometimes they may limit their emotional engagement with the patients and the families. So withdrawing into that crisp, efficient manner. So going all the way back to earlier chapters, that high technical quality of care, but low emotional quality of care. So this may come across as very cold, very disconnected from the family and the patient side of things, but it may be an effort to protect themselves. So if I'm going to lose you, I don't want to get too connected to you. For physicians, a lot of times they're tasked with allocating too little time to too many patients and too much work. They may choose to allocate more of their time to the patients that can really benefit from it, such as curative care patients. But for the palliative care patients, this may be interpreted as abandonment and maybe that they're inconvenient, a waste of time. So to minimize all this secondary distress on the patient and to uphold the values of palliative care, like making the person as comfortable as possible, physicians should strive to maintain brief but still regular contact with their patients. So working with the terminally ill is tough enough. Working with terminally ill children is perhaps the most stressful of all terminal care. As the expression goes, a parent should not have to bury their child. It can be hard to accept that terminal illness exists in children. Both due to personal distress and a desire to protect the child from additional fear, both medical staff and the child's family may be hesitant to discuss the realities of the child's condition with the child. However, despite limitations in how children understand death at various ages, they're a lot more aware and a lot smarter than we give them credit for. Whether or not they're explicitly informed about their condition, they'll take cues from their environment and people around them so they can start to piece it together. How many medicines are they on? How many machines are around them or attached to them? How upset are their families? Like, are people crying a lot? What has happened to the people around them, like their roommate? So it may be difficult to know what to tell a child. So counseling is really common with terminally ill children to help them understand and accept their situation. But you do have to communicate and tell them something, because probably already know a lot more than you think they do. Typically, counseling with a terminally ill child follows some of the same guidelines as counseling terminally ill adults, but there are some notable differences. The clinician takes cues about what to talk to the child about from the child, and only discusses what they're ready to discuss, and not pushing for further exploration, so you're not trying to work on those defenses. Parents and caregivers, too, may need their own counseling to help cope with the death of their child. It's common for caregivers to blame themselves for the child's condition, thinking they could have done more to prevent it. If there's more than one child in the home, it really swings the balance of where resources are allocated, and the child may be struggling to cope with the condition of their ill sibling or cousin or whatever. Further, the child's needs may be overlooked due to the severity of the terminally ill child situation. So to restore family balance, working with a counselor to address these issues may be beneficial. Additionally, enormous amount of the caregiver distress may lead to the development of symptoms of post-traumatic stress disorder, PTSD. So therapy for the caregivers may be required to cope with these developing symptoms and to help them accept and cope with the child's diagnosis and eventually their death. And these may be needed as death approaches and after it's happened. So the demands of terminal care often stretch the resources that a traditional hospital is designed to provide, because the patient requires constant care, and palliative care often involves aspects that may not be permitted in traditional hospital care, like personal items in the room, increased visitation. So as alternatives to hospital care, hospice care is care in one's home or in a hospice facility, and it's becoming a much more favorable option. Hospice care is built on the value of accepting death and emphasizing relief of suffering instead of loss of life, and instead of trying to cure an illness. Hospice care is designed to provide palliative care and emotional support to dying patients and to their family, and comes from a hospice in medieval Europe. So in medieval Europe, a hospice was a place that provided care and comfort for travelers, traveling far from home on their own. So the idea of a hospice is a philosophy that's focused on how someone dies, emphasizing dignity and comfort, and a system of care for the terminally ill. Typically, treatments that are painful, invasive, uncomfortable are discontinued. Again, trying to emphasize we're not trying to cure anything anymore. Let's just enjoy what time's left. And care is refocused to managing symptoms and maximizing comfort. So especially like controlling pain, controlling nausea. Most importantly, psychological comfort is stressed. So they may be encouraged to personalize their living areas, wear their own clothes, determine their own activities. Hospice care can be oriented towards improving and maximizing a patient's support system as well. So as much as possible, restrictions on visitations are removed. So like I said, exceptions for palliative patients with COVID-19. Staff are trained to emphasize warmth and connection in their interactions with patients and their families. So in comparison, home care is the idea of the person remaining in their home, not even being in hospice, and having only the necessary medical care. So being surrounded by their own possessions, their own families and loved ones, possibly having, in-home nurse, but everything's done in the place that they live. So this appears to be the care of choice, understandably, for most terminal patients, because in some ways it might be the most economically feasible. And there's a lot of psychological advantages arising from the familiarity and emotional connection to that environment. Like, this is your home. You feel more comfortable at your home. There's also, again, it's a lack of painful, invasive treatments. We're not trying to cure anymore. And the higher degree of control the patient can maintain over their own care, their own environment, their own activities. However, the family may experience increased stress. And usually at least one family member must be devoted to the patient's care at all times, even if there is, 24-hour nurse care that can be afforded by the family. In addition to the time and financial constraints of around-the-clock care, the family member must face their loved one's deteriorating condition and approaching death at all times. So if you're caring for someone 24 hours a day, you have the realities of their situation, the upcoming death, the impending loss in your face all day. So it's really common for people to kind of be dealing with two desires. On one hand, you don't want to lose them. You want to keep them alive. You want to keep them with you. But on the other hand, you want the suffering to end, both your own and theirs. So this can result in a lot of guilt over the idea that in some way you're hoping that that your loved one dies. So clearly, death is difficult for the deceased, and especially when they knew their death was coming, and for the people left behind, the survivors of the deceased. So as death is inevitable, whatever its cause, focusing on the survivors and understanding the experience of the survivors is important in health psychology research and intervention. Dying is a busy time to risk sounding insensitive. It's very busy to die, because the person and or their survivors need to prepare for the death and have a lot to deal with after the death. So any after-death rituals like funerals, receptions, burials. Additionally, the survivors need to handle the division of the assets, settling the estate, and then abruptly, it might take a while, but abruptly it's over. The individual's gone. They've been buried, or whatever the family decided to do, whatever the person wanted. The estate is now settled. So there isn't that much left to do, and you don't have to care for them anymore. You don't have to do anything. It's all done. They're gone. So a common experience, understandably, is grief. So by definition, it's a psychological response to bereavement, and it's marked by feelings of hollowness, preoccupation with images of the deceased, expressions of hostility towards others, guilt over the death. And people who are grieving are often restless and can struggle to concentrate, maybe angry or depressed, and this is particularly true in that first 6 months following death. Even the most empathic outsider can struggle to understand the extent of one's grief, especially if the death was a long time coming compared to if it was sudden. And becomes a certain point, because as a friend of the person grieving, it's much easier for us to move on compared to the person who's actually in a stage of grief. So there may also come a point where you want to encourage them to let go and keep going, but the person may or may not be ready to do so. For example, many widows report that after a few weeks, people begin to encourage that, you pull yourself out of it, get on with your life. They would want you to move on. They wouldn't want you to be like this. And while well-intended, in reality, normal grieving can go on for months. And while eventually the person should return to their new form of normal, you can still continue to feel like troubled by their loss years later. Often grief is more aggravated in men, in caregivers, and those who experienced a sudden and unexpected loss. So being a survivor, particularly a widow, can create additional life stressors and burdens. Much of this ties to leftover gender stereotypes. So in the home, workplace, and pay disparity. So among women, financial strain appears to be a primary burden. For men, strains associated with household management are key, particularly if they're widows with children to care for now. Children can be providers too, so particularly survivors of lost parents or siblings. The loss of a sibling can be particularly difficult and result in a lot of guilt, because almost any child has either said out loud to someone or no one, or thought to themselves that their sibling was dead or, somehow gone. So for the children to whom this actually happens, they actually do lose their sibling, this can result in an increased amount of of guilt, because they may feel that they somehow caused it or somehow willed it into existence. Further, the loss of a sibling can result in an increased, again, a swing in attention, but now back to the remaining child or children. So if the surviving children had experienced a reduction in attention because of the dying child, they may feel a bit of happiness and relief that attention has been restored, or maybe they're even getting more. To help a child prepare and cope with the loss of a sibling, it's best for them to be prepared ahead of time. So again, kids know and understand a lot more than we think they do, even if it's not exactly how an adult understands it. It may be helpful to prepare them for the implications of death, what it means, what it's going to look like, and answer their questions as honestly as possible in a language that they can understand, without providing unnecessary detail that might frighten them. As with the counselors, discussion with a child should follow the child's lead. So information should be provided when the child is ready and when they ask for it. So obviously it's important to talk about death, as uncomfortable as it may be. And because it can be uncomfortable and people like to avoid it, there's a lot of misconceptions about death and how to approach and interact with someone who's dying. One existing intervention to remove these misconceptions is death education. So with death education, as it sounds, the goal is to develop realistic expectations about death. So this includes what modern medicine can actually achieve, because we can do a lot now, but modern medicine can't cure everything, and it's not perfect. It's far from perfect, and there's a lot of limitations to it. So understanding those, and also understanding what most dying individuals actually want and need. Obviously everyone's different, but do they really want to not talk about it, pretend it's not there? Should you just ignore the elephant in the room, that they're dying? Should you just leave them alone? So talking about the realities of death and dying as the dying person sees it. Unfortunately, the best means to develop a large, organized form of education would be to develop post-secondary courses. So the majority of recipients are college university students, which, no offense to us, but much of the general population then doesn't receive this training. Nonetheless, it can be a valuable opportunity for these students to learn, and hopefully they can disseminate that information to other people. So, maybe courses on dying can include volunteer work with dying patients, like volunteering in hospice care. However, there's definitely a potential area of concern regarding students' motivations to attend these courses. So specifically, normalizing death may unintentionally provide some encouragement for self-destructive learnings, particularly among suicidal individuals. Being aware of this potential risk is important, and instructors of these courses have encouraged that any suspicions be confronted head-on. So there's a lot of research showing that talking about suicide will not lead a person to try and die. So discussing concerns, asking if they're suicidal, can actually provide that safe space to talk about how they're feeling. So there isn't a whole lot you can do to prevent it. You can't screen everyone that signs up for a course, but being aware and confronting it head on may help. So to wrap it up for chapter 12, despite the limitations and the stigma, many people do actually want to learn and understand death, but there isn't a lot out there. So the more people educate themselves and then educate others, the better an experience with death you may have, as difficult as it is. Try and make it as comfortable as possible. So that wraps up chapter 12. Chapter 13 will be on its own video, as will 14 and 15. And as I will say, as I read 13 and 14, I did find it was quite repetitive, drawing on information from earlier chapters, like let's talk about these specific illnesses, and then let's talk about how relaxation is used and CBT is used, and repeat. So I may try and spend some more time focusing on the initial details about the illnesses themselves, and then summaries on the more repetitive things. So if, as that comes up, if you have any questions or you need me to elaborate on things, you can always reach out to me, or if you have any general questions. But otherwise, get cracking on those second journals and take care.